Welcome everyone to the Maternal-Fetal Medicine, BI Leahy Health, BIDMC Obstetrics and Gynecology webinar. My name is Brett Young and I'm one of the Maternal-Fetal Medicine attendings if I haven't met you before. So thank you for coming virtually. Great silver lining of the COVID pandemic to try to be able to spread education virtually. So thank you again for coming. And today I'm going to be talking about the management of anemias and thrombocytopenias in pregnancy. And I'm one of the maternal-fetal medicine attendings here, as I said, and I have a strong clinical interest in hematological disorders in pregnancy. And we have a multidisciplinary joint clinic here at Beth Israel, and I serve as one of the co-directors of the Hematological Disorders in Pregnancy Clinic, and always happy to receive emails or referrals if we can help in any way. I have no conflicts of interest. So let's go through our objectives. Today, we are going to discuss obstetrical management of common thrombocytopenias in pregnancy. We're going to review the differential diagnosis of thrombocytopenias and anemias during gestation, discuss the obstetrical risks associated with maternal anemia, and then finally review obstetrical management of iron deficiency anemia in pregnancy. So let's first start with thrombocytopenia. There are a number of causes of thrombocytopenia in pregnancy. We can think about obstetric causes, infectious causes, systemic conditions, immunologic conditions, with of course the two or three major conditions that we think about, gestational thrombocytopenia being the most common, ITP, and then of course causes of thrombocytopenia secondary to obstetrical conditions such as preeclampsia with severe features or HELLP syndrome. Today, when we talk about thrombocytopenia in pregnancy, we're really going to focus in on gestational thrombocytopenia and ITP. So let's start off with a case for maternal ITP and thrombocytopenia. So this is a patient who is in her first pregnancy. It's complicated by known ITP and chronic hypertension. She is intermittently on prednisone during her life, depending on how severe her thrombocytopenia is. She underwent, this patient, a splenectomy when she was 12 for a platelet count of 1,000, a platelet count of 1. And since the age of 12, she's been managed on prednisone anywhere from 20 to 40 milligrams daily to keep her platelet count over 30,000. That was their goal, not pregnant. That was the same goal that we had during her pregnancy. And so we managed her in pregnancy with serial platelet counts with a goal of over 30,000 throughout pregnancy until 36 weeks. And then with a platelet count goal of 70 to 80,000 starting at 36 weeks, following weekly until delivery. So let's get into a little bit more about the workup for thrombocytopenia. So when we are presented with a patient with thrombocytopenia that is new and may not have a diagnosis of ITP like this patient did, we should get an obstetrical history. Does this patient have a prior history of gestational thrombocytopenia? We know that patients who have a history of prior gestational thrombocytopenia have a 14-fold increased likelihood of recurrence in the next pregnancy. We should try to see if the patient has had any complete blood count at a prior physician's office, either in a prior pregnancy or at another visit or with her primary care provider. We should get a sense of when the thrombocytopenia started in the pregnancy, so timing of onset. And certainly in the third trimester, we should be thinking about the potential for obstetric causes of thrombocytopenia, and that would of course include HELLP syndrome or preeclampsia with severe features. We also can think about a very rare condition called TTP that can be exacerbated in pregnancy. And other things we should be thinking about are the possibility of infections. So could this patient have a new diagnosis of HIV, like a recent patient of mine who presented with thrombocytopenia that was how she presented with new diagnosis of HIV. Could she have H. pylori? And should we evaluate her and get her referred to GI if that is a concern? Is this secondary to a medication effect? So we know that certain medications such as anticonvulsants, antimicrobials, such as actually Bactrim and cephalosporins may actually cause thrombocytopenia. And then finally, additional workup. We should probably think about not only getting a CBC to make sure that all other cell lines are appropriate, but also possibly thinking about getting a blood smear to look for any clumping. Sometimes we will see thrombocytopenia secondary to pseudo-thrombocytopenia, otherwise known as clumping of platelets, and we can detect that on a blood smear and then can use a yellow top or a different type of tube to really prevent that clotting, the clumping, and get an appropriate true platelet count. We do know that in general, patients, and this came from a study of about 1,100 healthy patients without any known thrombocytopenia. This is a retrospective study. And the mean platelet count at delivery was 234,000. However, the lower limit of normal was 124,000. So many of our patients will have platelet counts under 150,000. And we're going to talk about diagnosis of ITP. But many of our patients will have a platelet count of, let's say, 130,000, which actually is just considered a normal variant. So as we spoke about, two of the most common etiologies, I'm not going to talk about preeclampsia or HELLP syndrome today, but two of the most common etiologies for thrombocytopenia are gestational thrombocytopenia and ITP. When we think about gestational thrombocytopenia and ITP, it's really helpful to think through as best as we can, knowing that ITP is a diagnosis of exclusion. Do we think that this is more ITP, or do we think that this is gestational thrombocytopenia? And usually the platelet count may help us, and as well as the timing of onset of the thrombocytopenia. And we know that the typical platelet count and gestational thrombocytopenia is pretty usually over 70,000. It's pretty unusual that would be under 70,000 or under 75,000. And in ITP, we actually see predominantly that to make that diagnosis, you need to have a platelet count under 100,000. Again, 100,000, not 120,000 or 130,000. The timing of onset typically differ. In ITP, we will see more commonly in the first trimester. The patients will present first CBC upon prenatal care registration, and will have thrombocytopenia under 100,000. We should be thinking about ITP along with other etiologies as discussed previously. And then gestational thrombocytopenia, as we all know, typically occurs in the second or third trimesters. Treatment, we're going to get into this, but treatment for gestational thrombocytopenia is typically expectant management. Prednisone, the studies on prednisone with gestational thrombocytopenia really don't demonstrate significant difference. There may be some efficacy in some cases, but it's not consistent. And in ITP, we ideally want to keep a platelet count of 30,000 up and over 30,000 throughout pregnancy until 36 weeks. We'll talk a little bit more, but typically treatment of thrombocytopenia from ITP is very similar in the pregnant population versus the non-pregnant population per hematological guidelines. In terms of newborn effects, important to really, and this is where obstetrical management and the risk for potential risk for newborn thrombocytopenia differs. Really, we do not think about a risk of thrombocytopenia with gestational thrombocytopenia. The likelihood of neonatal thrombocytopenia is really thought to be quite low, whereas in ITP, there's a low risk of thrombocytopenia, but certainly 1% or less risk, fortunately, of significant thrombocytopenia resulting in intraventricular hemorrhage. So let's dive a little bit more into gestational thrombocytopenia. So again, as we talked about, gestational thrombocytopenia is the most common etiology of thrombocytopenia that we see in pregnancy. It is a diagnosis of exclusion. So we actually typically cannot make a diagnosis of gestational thrombocytopenia until about 4 to 6 weeks after delivery, when we see that a patient had thrombocytopenia in pregnancy, and then afterwards that platelet count 4 to 6 weeks after delivery recovers. Most of the time, platelet counts are over 75,000. It's unusual to see a platelet count from gestational thrombocytopenia under 75. And if we need to be thinking, could there be a potential immune component like ITP coming into play? But gestational thrombocytopenia occurs in about 5 to 10% of pregnant patients. And when we see gestational thrombocytopenia, we recommend, and ACOG recommends, that we trend the platelet count every prenatal visit. And obviously our prenatal visits are going to be more frequent towards the end of pregnancy, but typically I follow platelet counts if I'm concerned about gestational thrombocytopenia, we'll trend platelet counts every prenatal visit, every 4 weeks, starting in the early third trimester, and then more frequently towards the end, accompanying their prenatal visits. As we talked about, there's really not thought to be, fortunately, a neonatal thrombocytopenia risk. The risk is thought to be about 0.1% risk of neonatal thrombocytopenia. Treatment typically is not indicated for gestational thrombocytopenia, and typically it's not necessarily an indication for induction of labor either. And as we spoke about, we know that gestational thrombocytopenia, we expect the platelet count to return to normal 4 to 8 weeks after delivery. If it is not, we need to entertain potential for other etiologies. So let's talk a little bit more about ITP, immune thrombocytopenic purpura, much easier to say ITP. So ITP is caused by maternal autoantibodies, antiplatelet antibodies. It's immune-mediated thrombocytopenia and occurs much less frequently than gestational thrombocytopenia, in about 1 to 2 out of every 1,000 pregnancies. However, of patients that have thrombocytopenia at delivery, it'll be about 3% of those patients who have ITP. So it's certainly, we all will see it in our careers. Typically, again, we would need, and the diagnosis requires that a platelet count needs to be under 100,000, and all other etiologies for the thrombocytopenia are excluded. So again, a good start if you are concerned about ITP is to get to check their history, see if you can get other blood counts, ask if they've ever had any easy bruising or gum bleeding during their lifetime, if they have family history, and then to get CBC and then a blood smear, and then would be reasonable to have a consult with hematology to get further information. But typically, again, need 100,000 or lower to make that diagnosis after other conditions have been excluded. Antiplatelet antibodies are actually not particularly useful for this diagnosis and don't have a strong role here in the clinical setting. When we think about ITP and the risk of neonatal thrombocytopenia, there's not necessarily a clear relationship between maternal thrombocytopenia and infant thrombocytopenia. Most of the studies, such as this graph here, you can see the infant platelet count and the maternal platelet count really do not have a correlation. But we typically, most studies have not found a correlation. Some have, but typically we do not necessarily think that the maternal platelet count necessarily corresponds with the risk of neonatal thrombocytopenia. But we do know that maternal ITP can have a risk on neonates, so let's dive a little bit deeper into that. So when we think about neonatal outcomes, the vast majority of neonates have uncomplicated outcomes in the setting of maternal ITP. However, 10% of infants born to patients who have ITP will have platelet counts under 50,000. 4% will be born to patients with ITP, and those neonates will have platelets under 20,000. Fortunately, despite that, the risk of intracranial hemorrhage or other major bleeding is thought to be less than 1%. When we think about who are the patients that are most likely to have neonatal thrombocytopenia in the setting of maternal ITP, we think about the risk of, or the history of maternal splenectomy. So kind of that case presentation that we're going to talk about and conclude, like the patient I took care of. Maternal splenectomy, and certainly not surprisingly, if there's a prior affected sibling who also as a neonate was born with thrombocytopenia. And again, maybe severe maternal thrombocytopenia has an impact, but not necessarily demonstrated in all studies. What we do not think is associated with neonatal thrombocytopenia, again, most of the time we do not think maternal platelet count is. Prior thrombocytopenia in the patient's lifetime, not associated with neonatal thrombocytopenia, and prednisone use is actually not associated with thrombocytopenia either. As we spoke about, treatment for ITP in pregnancy is really the clinical guidelines from the American Society of Hematology, most recently in 2019, recommended that treatment should be similar and similar guidance for pregnant versus non-pregnant individuals, which is, again, to keep the platelet count above 30,000, avoid spontaneous bleeding, and increase the platelet count with either prednisone or IVIG for anticipated procedures, including, of course, a vaginal delivery or a C-section. So during pregnancy, we would recommend trending the platelet count during pregnancy, and often these patients are followed in a multidisciplinary fashion with maternal-fetal medicine or with hematology. And certainly platelet counts more frequently are obtained towards the end of pregnancy. Think about having additional counseling from anesthesia. And then in the late third trimester, we of course need to think about ongoing evaluation for other obstetrical etiologies, including preeclampsia or HELLP syndrome. Typically, patients, when they undergo an anesthesia consultation, the anesthesia guidelines recommend that it's reasonable to pursue regional anesthesia as long as the platelet count is over 70 to 80,000. And I know that there's a range, and many of our patients may have a platelet count close to that. But I think we do know that patients with ITP, those platelets are bigger and they work well. So when you look at a smear for a patient with ITP, those platelets, and you look at them, they're larger than patients who have more platelets, but their platelets are smaller and they don't have ITP. So platelets in the setting of ITP are, while not necessarily plentiful, they are strong platelets and work really well. So there are many anesthesiologists, as long as the platelet count is demonstrated to be stable at 70,000 or more, should be able to get an epidural in labor if they desire. So first-line treatment for ITP is prednisone and also IVIG. Let's talk about them a little bit. So prednisone dosing, typically we would start with 10 to 20 milligrams initially. So if you are getting towards 35, 36 weeks, you've been getting weekly platelet counts, and you and the hematologist, if you're working with a hematologist or maternal-fetal medicine, we want to increase the platelet counts, we can start with 10 or 20 milligrams of prednisone starting around 36 weeks. We can go up to 0.5 to 1 milligram per kilogram. We typically see that prednisone is going to work the response time for the platelets in 4 to 14 days. So the response time is slower compared to IVIG. And we expect that the prednisone, if we gave some dose once the platelets responded, it would last for about 1 to 4 weeks, of course, very variable. Side effects, certainly prednisone can cause difficulty sleeping, can cause hyperglycemia, hyperactivity, and also can cause hypertension, something that I don't think that I typically think about. When we think about IVIG, the typical starting dose is 0.5 milligrams per kilogram. It's an infusion, often takes a couple of hours depending on the patient's weight. But the platelet response time is faster than prednisone, with a platelet response time typically within 1 to 3 days. And the durations we believe is about 2 to 3 weeks, does vary over time, but 2 to 3 weeks. And typically is tolerated without many side effects, but the more common side effects that we would see would be headache, chills, fever, myalgias, or joint pains. There may be some hematologists that prefer the use of IVIG, and I take care of a lot of patients and their hematologist prefers starting with IVIG, or some prefer prednisone. There's not necessarily one that's necessarily better than the other, although certainly they have a different cost. They have, with IVIG being more expensive, they have a different platelet response time with IVIG, typically having a faster response. And there are some patients that we know based on prior experiences that either IVIG or prednisone will work better. And some patients with ITP may not respond well to prednisone, whereas some are non-responsive to IVIG. So it's helpful to know that history for both you and the hematologist moving forward. One study that, and one question that sometimes we get are, should we be giving steroids? And if there are, if we do give steroids such as betamethasone, that a fluorinated corticosteroid that will cross the placenta, as we all know, versus prednisone, does that affect fetal or neonatal platelet count? And this was a study back in 1990, but betamethasone administration is actually not thought to change the fetal or neonatal platelet count. This was patients with ITP who were randomized to this is back in 1990, but 1.5 milligrams of betamethasone daily or no treatment. And based on that dose, there was no difference no clear benefit for betamethasone administration on fetal platelet count. So mode of delivery. As we spoke about, typically there's a very low risk, fortunately, of intraventricular hemorrhage for neonates, regardless of mode of delivery. And we should typically reserve cesarean for usual obstetric indications. and minimize, so reserve cesarean. However, sometimes we are left with a scenario of a patient pushing for a while with ITP. And I think this is a nuanced point, but do you want to make it that, we can potentially have an operative assisted vaginal delivery if the benefits outweigh potential risks. There are small theoretical concerns that using a vacuum or possibly forceps may increase the likelihood of intraventricular hemorrhage in the setting of a fetus that we may not know will have thrombocytopenia. And so when I'm doing my consults, I am very careful to use the phrase that we should minimize the use of vacuum-assisted vaginal delivery, but I think we all understand that there may be a scenario where a patient's been pushing, has a category 3 tracing, and you know that you can get the baby out very quickly with the use of the vacuum at +4 station versus running her running the patient to do a stat C-section that might take longer than doing a vacuum there in the room. So I think that we typically want to minimize the use of operative assisted vaginal delivery in the setting of ITP, but there may be some scenarios where the benefits of operative assisted vaginal delivery may outweigh potential risks of IVH. And then another point that I think is in the also recommended by ACOG that I think is really helpful for the pediatricians is to collect cord blood to send for neonatal platelet count. And I think this is important for anyone who has had a history of ITP. When patients have had splenectomy, they actually may have a normal platelet count. And that doesn't necessarily mean, even though the maternal patient's platelet count is normal, that there are not antiplatelet antibodies that are not crossing the placenta and causing thrombocytopenia. So it is recommended to collect a cord blood, a red top, to send for a neonatal platelet count, and then that can guide the pediatricians for follow-up and help them after delivery, given again the risk of neonatal thrombocytopenia with ITP. So to follow up, our patient with ITP, she presented in spontaneous labor with a platelet count of 85,000 when she arrived to labor and delivery. She was on 60 milligrams of prednisone daily at that point. She received an epidural at her request, and she had an uncomplicated vaginal delivery without a postpartum hemorrhage. Most patients with ITP will, as we spoke about, have fewer platelets, but they are mighty platelets, big mighty platelets. And postpartum hemorrhage is actually unusual for patients that have at least a minimum of 30,000 for vaginal delivery and ideally 50,000 or more for cesarean. But this patient had an uncomplicated vaginal delivery. Unfortunately, her neonate did have a platelet count of 10,000, requiring transfusion and IVIG. And her daughter had a small germinal matrix intracranial bleed, which again is really unusual, but did have a platelet count of 10,000. This patient, again, as a reminder, had a splenectomy, which is one of the strongest risk factors for patients to have neonatal thrombocytopenia. Her platelet count was trended during her labor course and immediately after delivery, and trended down to 56,000. So she got an additional dose of steroids, and then the anesthesiologist felt comfortable removing her epidural and was removed after this additional dose of steroids when her platelets were above 70,000. And then postpartum, her prednisone was weaned, and the patient did well and actually went on to have a second baby that I took care of her pregnancy and did well with, again, recurrent neonatal thrombocytopenia, but fortunately not as severe as this pregnancy. All right, so let's transition to anemias anemia in pregnancy. I, again, love talking about blood. I find it just a fascinating topic to talk about. And in the top right-hand corner, you'll see a picture of red blood cells. Want to start off with that. So let's talk about anemia in pregnancy. Let's talk about some demographics and definitions. So the WHO defines anemia in pregnancy as mild anemia with a hemoglobin. The WHO uses hemoglobin of mild anemia of 10 to 11 grams per deciliter, moderate anemia, 8.5 to 10, sorry about that typo there, 8.5 to 10, and severe anemia with a hemoglobin of less than 8.5. We know that in pregnancy, about 50% of anemia in pregnancy is actually secondary to iron deficiency anemia. And the diagnosis when we diagnose iron deficiency anemia actually comes from both a hematocrit and a ferritin level. You're going to see varying recommendations regarding ferritin levels. One of the most conservative ferritin levels is a ferritin level of less than 30. It probably depends on the lab that you're using. And in some other studies in the American College of OBGYN uses a ferritin level to define iron deficiency anemia of less than 18 nanograms per milliliter. Let's go through differential diagnosis of anemia in pregnancy. We can classify anemia in pregnancy either based on mean corpuscular volume, MCV, or it can be classified by production of platelets versus destruction of platelets if there's an imbalance, and can also be classified as either acquired or inherited. I most commonly use MCV to classify anemias. So microcytic anemia is most commonly, the most common etiology is iron deficiency anemia, which we're going to focus in on today. Thalassemias, sometimes we'll see in the setting of anemia of chronic disease, and occasionally lead poisoning, although I've actually never seen that in practice, and I've never seen copper deficiency either. Normocytic, sometimes we will see iron deficiency anemia that's early onset with a normocytic MCV between 80 to 100. Any acute blood loss may still have normocytic anemia. Anemia of chronic disease, or a mixed picture of potentially iron deficiency anemia and a cause of macrocytic anemia can have a normocytic mixed picture. We can see autoimmune hemolytic anemia, hereditary spherocytosis, and a whole variety of different conditions, including renal insufficiency, significant renal disease causing normocytic anemia. And when we think about a macrocytic anemia, an MCV greater than 100, we think about folic acid deficiency, vitamin B12 deficiency, and those are two tests that we can very readily get during our workup for anemia in pregnancy. Anemia with liver disease, anemia associated with alcohol abuse too, which I do ask if I see a macrocytic anemia during pregnancy. I always want to make sure that we screen our patients for alcohol use in pregnancy as well. So why do we care about anemia? And it's obvious, but I wanted to go through at least one study showing risks of anemia during pregnancy with respect to blood transfusion and C-section. But we know that anemia increases the risk of many obstetrical complications in the intrapartum period, and then also can occasionally increase the likelihood of hypoxemia actually in fetuses when very severe, particularly when a hematocrit is less than 21%. But we know that anemia increases the risk of blood transfusion, increases the risk of hysterectomy as well. This was a study published in 2006, blood transfusion and cesarean delivery by Dr. Rouse et al. Through the MFMU. And they looked at rates of blood transfusion, what was really driving rates of blood transfusion. And one of the most common things that they saw was not only a mild anemia, but also severe anemia, not surprisingly, increased the likelihood or odds ratio for packed red blood cell transfusion. So when patients had a hematocrit of less than 25%, these patients had a 17-fold increased risk for needing a transfusion. And if patients had a mild anemia between 25 and 29%, that risk went up by about 4-fold. And so that leads us to, again, when we think about caring for our patients with anemia in pregnancy, is there something that we can do as obstetricians during their prenatal care to try to reduce the likelihood of blood transfusion? So when we think about workup for anemia, we get an initial CBC at the time of registration, and if at prenatal registration, the first trimester, their hemoglobin is less than 11, we should think about various causes for this. Probably first step would be to draw a ferritin level. I also frequently get folate levels and vitamin B12 as well. And typically the MCV can help us determine whether we think it's more likely to be iron deficiency or not, but sometimes we're actually surprised we can have a mixed picture. But if the ferritin level, again, depending on the study that you use and whether you want to have a broader catchment for enrolling patients to put them on iron. If their ferritin level and their hemoglobin less than 11, the ferritin is less than 30, or at a minimum less than 18, we should start the patients on an iron trial, and recheck a blood count in about 4 to 6 weeks. And that's in the first trimester. In the second trimester, if their hemoglobin is between 9 to 11, so more significant anemia, again, try iron, recheck the CBC 4 to 6 weeks later. And if still persistent after an oral iron trial, should strongly consider use of IV iron, and we're going to go into that. And certainly if a patient has a hemoglobin less than 9 in the first or second trimester, hemoglobin less than 9, or other high-risk factors, which might be known accreta, placenta previa, second or third C-section, if we should think about starting initially with IV iron. And ideally, if patients are in the third trimester and we have less of time to catch up in the third trimester, we should probably think about proceeding on with IV iron initially, as we know that studies, which I'll show you in the next slide, do demonstrate better efficacy with IV iron compared to oral iron. If a patient we do not think that they have iron deficiency anemia, and their ferritin is greater than 18 or greater than 30, depending on which guideline you're going to use, one should then look at their MCV and think about other etiologies if we do not think that this is iron deficiency anemia, and look at their hemoglobin electrophoresis, make sure that they've had molecular testing for alpha thalassemia, because electrophoresis will not exclude alpha thalassemia. You need molecular genetic testing to look for that. And if their MCV is higher than expected, greater than 90 to 100, think about vitamin B12 and folic acid levels if you haven't gotten them already. So a little bit about oral iron. We know that oral iron, there have actually been some studies looking at which is more efficacious, and is there a difference in frequency? And there actually was a study recently looking at use of daily iron versus every other day iron. And interestingly, the absorption with every other day iron was actually higher than daily iron. So, and then they also looked at is there any difference between daily iron versus twice daily iron? And I will tell you that not infrequently I will place patients who have anemia, and I'm trying to bolster their iron counts in the second trimester with oral iron. I will not infrequently put them on twice a day or 3 times a day iron until I read this study. And this study actually does not demonstrate efficacy necessarily with twice or 3 times a day iron, but maybe better efficacy with every other day iron rather than daily. If we are giving IV iron, we can think, and usually I typically order iron sucrose through our infusion center. 200 milligrams every week is usually how I order it, although you can do it every other day to replete up to 1,000 milligrams. I usually start with 200 milligrams every week of IV iron, and I get 3 to 4 infusions depending on the severity of their iron deficiency anemia. And then we'll repeat a CBC 4 to 6 weeks after completion of the IV iron. And as we spoke about, I mentioned a couple of high-risk factors, but off to the bottom right, any patient who has a bleeding disorder, placental abruption, placenta previa or accreta, history of gastric bypass because of concerns of malabsorption of iron, particularly Roux-en-Y, a patient who may be declining blood products due to religious preferences, Jehovah's Witness patients, or patients who are having twins or triplets who are at increased likelihood of hemorrhage at the time of delivery, or a patient with a prior history of postpartum hemorrhage. So thinking about more about dosing of oral iron and IV iron. So first line treatment for iron deficiency anemia, once we diagnose iron deficiency anemia, as we spoke about, oral iron, diet supplementation, and you can see the picture on the bottom left. Foods that are high or rich in iron include canned tuna, although may want to potentially make sure that mercury content and not have significant replacement of that during pregnancy. Oatmeal, spinach, almonds, legumes, liver, and any red meat, egg yolks, almonds, and dried fruit and raisins are pretty iron-rich foods. And those might be areas to target if patients are trying to increase with diet supplementation their iron stores. And then oral iron. And as we spoke about, there is one study that demonstrates that daily iron versus twice a day iron, at least in this one study, daily iron once a day had better absorption versus twice a day iron, or no difference in twice a day iron. And perhaps even every other day iron increased absorption. But ferrous gluconate and ferrous sulfate are two of the oral iron formulations that have the lowest risk of adverse side effects, with the most common risk of adverse side effects, as we know, being constipation. And then when we think about IV iron, there are many different formulations of IV iron. I most commonly use iron sucrose, although ferric carboxymaltose, ferric deoxymaltose, ferrimoxetol, or low molecular iron dextran, depending on what your facility has, are all reasonable to use in pregnancy. The likelihood of allergic reaction to IV iron use was thought to be higher previously, and overall likelihood of allergy to IV iron is really quite small. And my preference is to use iron sucrose because it's the dosing that I remember most easily. And again, I use 200 milligrams every week, and typically start off with 3 doses, although it'd be very appropriate to aim for 200 to 300 milligrams with each dosing, with a goal of about 1,000 milligrams for repletion. When we think about efficacy versus oral iron versus IV iron, it's been studied pretty extensively. And this is a meta-analysis of randomized controlled trials of pregnant patients with iron deficiency anemia treated with IV iron versus oral iron. And you can see that when we looked at studies, and looked at meta-analysis, that IV iron was more efficacious in a shorter amount of time at bumping platelet count. And in some trials that have looked at their outcomes, not only looking at hematocrit, but looking at transfusion levels, the likelihood of transfusion with IV iron versus oral iron was lower with IV iron. So particularly if we're getting into the 3rd trimester, we may really have an opportunity to potentially reduce the likelihood of transfusion by reducing the severity of the iron deficiency anemia with administration of IV iron. So in summary, I want to make sure that we left time for questions. Today, our objectives were to review obstetrical management of common thrombocytopenias in pregnancy, and hopefully that was helpful. To list the differential diagnosis of thrombocytopenias and anemias in pregnancy, to discuss obstetrical risks associated with maternal anemia, and finally to review obstetrical management of iron deficiency anemia in pregnancy. So hopefully that was helpful. Our upcoming educational webinar is Thursday, November 18th at 5 p.m. with Dr. Liberty Reforma, our senior fellow, who's going to give fetal growth restriction clinical updates. So we hope that you can join us and get some CME credit available and learn virtually. And hopefully these webinars are helpful to you. And here is my email if I can answer any questions, but obviously if you want to put any questions into the Q&A, I'm happy to answer them as well. Thank you. Any questions that I can answer about anemias or thrombocytopenias, I'm happy to answer, or on any related topics that I didn't address today in my slides. Great question. So someone asked, are there thoughts about adding vitamin C with oral iron? So that is a great question. And yes, there are some studies that do show that adding vitamin C may increase the absorption of oral iron. So I think that doing supplementation is reasonable. A lot of patients who are taking a prenatal vitamin that will already be in their prenatal vitamin, but vitamin C, excessive amounts or additional amounts are not thought to be harmful. So I think adding an additional tablet of vitamin C may help with oral iron absorption. Great question. Another question, great question. ACOG had a paper published about a lower threshold to treat anemia in African-American patients. Are there set numbers that we should look for in that subset population? That is a great question. I am not aware of differences per se in thresholds for African-American patients versus non-African-American patients, although we do know that due to a number of factors that African-American patients have a higher likelihood of morbidity intrapartum and higher risk potentially of being undertreated during their prenatal care for a variety of reasons. And then also subsequently having complications with such as transfusion in pregnancy. One of my colleagues and I think Dr. Laura Smith is on this call. She and I are looking at this question that, with the big question of can with better IV iron treatment for certain patients, can we reduce, particularly looking at the African-American population, can we reduce that? So I think that question is a great one and more research is needed. Another question, does IV iron generally have to be given by a hematology department? The answer is no. So any infusion center can give it. I order it myself. I do not have my patients who have iron deficiency anemia that I clearly know with the ferritin and with their MCV and their hematocrit. I use hematocrit that they have iron deficiency anemia. I order that IV iron myself. And for the person asking the question, I'm always happy to walk through that order set. It's done through our infusion center here at Beth Israel, but I know it's done at community hospitals as well. And sometimes the our hospitals in our network have great opportunities to get their patients into the infusion center, whereas here the appointments may be a little bit tighter at Beth Israel. But IV iron can be ordered by the obstetrician, and I think once you order it a couple times yourself, you're going to feel really comfortable doing it, but I'm happy to help walk you through the first couple times you do it. But I think IV iron is probably underutilized by obstetricians, and there is a push, again, nationwide to reduce the risk, of course, of morbidity and even mortality from postpartum hemorrhage to bolster our patients who have more significant IV iron deficiency, iron deficiency anemia, and we can do that through IV iron. So another great question, how do I generally counsel my pregnant patients about the risks and side effects of IVIG and also IV iron? Great question. So if I am giving IVIG, which I typically do not give myself, I usually have hematology give it for ITP treatment. But typically IVIG is well tolerated, although the most significant risks that we think about are significant headache that occurs in 1% or less of patients with aseptic meningitis. So that would be from IVIG. I'm typically not ordering it myself for ITP, but if I was using it for another, such as treatment of NATE, FNATE, for IVIG, I typically quote that it's well tolerated. Typically, the infusion can take a long period of time, and to be watchful for any fever or for any significant headache. If they have a significant headache, they may need to come in for evaluation for further workup. And how do I counsel patients about IV iron? Great question. I typically counsel them that IV iron is quite well tolerated. There had been prior concerns, as I alluded to, about the risk, very small risk of anaphylaxis, and that's really not seen with the iron formulations that we went through today. And again, I use iron sucrose as my go-to IV iron. But IV iron, the infusion typically takes, less than an hour. It's sucrose in normal saline in 250 or 500 cc's of normal saline. It's tolerated very well with low risks of adverse issues. less likelihood of the constipation that oral formulations have. And the reason that it's more efficacious is the thought that it's absorbed better rather than being absorbed through the gut. So IV iron better tolerated typically by patients, low risk of complications such as very low risk of anaphylaxis or adverse reaction, and again, tolerated quite well. If there are any other questions, I'm happy to answer them, but I'm really appreciative of all of you who came and joined, and thank you for coming. And if there are any other questions, if not, we can sign off and be safe and be well, and thanks for joining us. I don't see any other questions, so we will sign off. And again, thank you so much for joining. Come join us in November for our next webinar on fetal growth restriction by Dr. Reforma. Take care. Bye-bye.